the General Practice Podcast from Ockham Healthcare, supporting innovation in general practice.
Welcome to the General Practice Podcast. This episode is brought to you in partnership with Practice Index. We chat today about the upcoming changes to the GP contract, which will have a real impact across primary care, from finances and recruitment through to staff retention and day-to-day practice management. And this is where Practice Index can help. The Practice Index Hub brings everything together in one place, helping you manage HR, learning, finance, compliance, and rotas all in a single system with one login. So, if you're looking for a simpler way to manage the operational side of your practice, it's well worth taking a look. Just head over to practiceindex.co.uk to find out more and book a demo to see how it could work for your practice. Well, I'm delighted to be joined today by Ceri, Chaplin and Pete Maynard. Now, you've both been on the podcast before, but just for those who maybe haven't heard you, just remind us what your roles are and what you do. Pete, let's start with you.
So I am the managing partner at Horfield Health Centre in North Bristol, and I am also one of the regional reps for IGPM.
And I am Ceri Chaplin. I'm the managing partner at Hereford Medical Group, or a single practice PCN in Hereford, and I'm one of the directors of the IGPM.
Well, it's great to have you both on. We got details recently about the GP contract 26-27. You've had a few days now to kind of digest what was in there. Maybe we could kick off with kind of what your overall impressions were and whether you were pleased with what you see or whether you weren't. Pete, let's start with you. You told me before that you were quite maverick, so I'm interested in what you have to say.
I'm going to bore you now and disappoint you. I think overall, we still don't have sufficient detail, as ever, to really interpret exactly what is being proposed. From my personal point of view, we knew money was going to be tight, so we didn't expect vast amounts of new funding to come in. But I still do get quite disappointed with the way in which these banner headlines say X 100 million is being reinvested, whereas in fact, a lot of the money is just being recycled. And I think that is unnecessary and misleading. And I think that's where currently the Department of Health are missing a trick, because I think if we could have a bit more honesty in the relationship, then I think we could all work better together.
How about you, Ceri?
I don't disagree with what Pete said. As you know, the IGPM were one of the groups that were consulted as part of the contract negotiations, as they were termed, or consultation, earlier this year. Some of the things that are in there are not a surprise, because we did see them and we gave some fairly strong feedback to NHSE about our thoughts as from a practice management perspective. And in fact, some of the things that we said were changed. It would be wrong of me to champion the fact that we managed to change everything, because we didn't. We gave some feedback that wasn't included when the final contract has come out. And of course, we weren't involved in anything that related to finance. We didn't have any sight of any of that. So I think we're in that position of not a huge surprise about the sorts of things that are in there. But as Pete said, the devil is in the detail, and we don't know some of that yet.
Well, let's start with the money, because the headline number is 485 million. But given that last year that was 889 million, so it's like half of the rise that general practice received last year. And I know there was some cover for the rise in national insurance, but even so, they're trying to spin that out as 3.6%. with a 1.4% real terms increase, which I don't really buy, because they're putting in there 2.5% for pay, but everyone knows that minimum wage going up 4.1%, gender for change pay deal 3.3%, so it's not going to be 2.5%, and it never is enough. It never translates into the percentage of GP costs that are in the contract versus the reality is never the same. So kind of seems to me that it's going to be, if anything, standing still. It doesn't feel like an investment in general practice. Or are you looking at it thinking, oh, well, at least we're going to get some new money?
As always, you can play around with the numbers. So there are lots of numbers flying around at the moment. We've got the uplift that's included as part of the contract that's been issued, or the details. There's the minimum wage, 4.1%. There's the fact that the wider NHS agenda for change has been suggested 3.3%. We don't know what's happening with DDRB. But the reality is that as practice managers, we have to look and say, how do we balance the books? And you've highlighted it as a thing to worry about, Ben. The national living wage, or the real living wage, whichever your practice pays, has gone up in double-digit growth in the last 5 years. And in most places, very few other roles will have gone up by the same percentage. And so actually all that ends up happening is we've got, at the lower pay scales that we will all use, there is that squeeze on our lowest paid roles, which it's important we pay well for. But the roles that sit just above them, staff are looking down and saying, well, hang on, what about me? And where is my double-digit growth? Now, clearly the contract can't allow for that, but it is good that there is more money, but the GMS are part of what we have as practices. So things like our immunisations, they're not going up. Other enhanced services aren't going up, or at least we haven't been given any indication of that. And so whilst the increase to our GMS value is appreciated, it's only part of what we earn. So if those other bits don't go up, there's a real terms cut in what we're being paid to do.
From my perspective, Ben, I'm really glad you raised that 889 million, because that really ties back into what I said earlier. When you broke down that supposed 889 million and you took off the lost QOF points, you took off the national minimum wage rise, you took off the NI increases that we were funding, you took off the staff salary rises, in fact, the figure was probably down to sort of 300 million tops, which when you balance that out across all the patients in England was about 30 pence per patient per day. And there's not many practices that can do a lot with an extra 30p per day. I think Ceri's absolutely right that there are so many other factors this time. And that, again, is where this smoke and mirrors comes in that I think is really unhelpful for everybody. If we knew this was genuine new money and wasn't as a result of recycling, for example, they've recycled some of the capacity and access stuff, then we'd have a little bit more faith. But it's difficult to be optimistic when you think, hang on a minute, let's see how this breaks down. We all use calculators, Practice Index have got some really good ones. We all use those to work stuff out and try and work out where our profitability is going to be. But it's really hard when you've got to suddenly take huge minuses from practice income before you add any of the pluses.
You mentioned the change to capacity and access funding for PCNs. So there's 292 million that is currently PCN funding. So it's capacity and access funding. Now that's money that PCNs are spending. Sometimes they give it to practices, but often they've set up services across the PCNs that's now going to go to direct to practices so that they can employ GPs linked to this, requirement to deal with all clinically urgent patients on the same day. What do you make of that? I mean, it's not new money, is it? It's money you were kind of getting through the back door rather than through the front door, and now you get it direct to practice. Do you think that is good for practices, or do you think it's going to create more problems that it solves?
I think it does possibly one or either of those. I think the reality is that when you look at the amount of money, the funding comes into force on the 1st of April. How many practices are actually going to be able to recruit a new GP by the 1st of April? Very few would be my answer. And if you actually look at, you can assume 15 grand for an annual sessional rate, including on costs. Average GP maybe works 5 sessions a week. And effectively the money set aside would fund just under 3,900 additional GPs if they all started on the 1st of April. So that won't happen. So it seems to me it's unlikely all that funding is going to be used. What happens to the balance? Does that get kept back or does that get recycled? Because a lot of PCNs were using capacity and access payments to fund other staff that were really important for the running of the PCN or the practices. So do we have to lay those off now? It's just really, really difficult to understand why they think this is going to be massively beneficial. If it came with no strings attached, different matter. But there are so many repercussions from it that I don't think it's easy or simple at all.
I think I would echo that. And we know that, in fact, it goes back to this issue about clarity. And when any contract issued, there are probably more questions than there are answers to start with. We've certainly heard from practices at the IGPM who have staff who are currently employed using that capacity and access payment money to support practice operations through the PCN. An example we've had from a member is a prescribing hub that's been set up and really supports and delivers additional appointments for those practices. We're not sure what happens with those employed staff, because if that money is being recycled into GP for practices, that's great. We're really happy that there is money coming for practices to employ GPs. But if it's at the cost of other members of staff, it kind of defeats the object. We've certainly written back to NHSC from the IGPM to say, what are the answers to these questions? But we're at that point in the contract. Like I say, we're waiting for further detail, really.
And I think, Ben, just to come back in on that, the other issue that is so important to so many practices, gets raised by IGPM all the time, is it's great having some funding to be able to employ some people. Where are we supposed to put them? Because the estate situation in general practice is dire, to put it mildly. And we've been banging on about this for years. We get money to employ staff. That's really great and we really appreciate it. But if we can't actually house them, if we can't put them in rooms to see patients, then how are we supposed to employ them?
Another big change is to ARRS funding. So it can be used not just for new GPs, but for all GPs. What's your make on that change? I guess there's been calls for a relaxing of the rules, but it does also look like the huge numbers of other staff that PCNs have been employing over the last 7, 8 years. Are we at a place now where they're potentially at risk because practices and PCNs will prioritise employing GPs over those roles?
I think that's a really good question. And I'd hate to sort of raise any concerns for people listening to this, but ultimately it will be for practices and PCNs to determine how that money is spent. Do they actively review and change their focus on recruitment, or do they wait and consider when somebody leaves how they fill that post? That's very much a practice or PCN decision.
I think it is really hard. As Ceri says, we've been given funding for what now, 7, 8 years, and we've been encouraged to bring other allied health professionals in. And I think in the main, that's worked quite well. I think we brought a lot of new skills in. I think the change to which GPs we can recruit under ARRS, that's a really welcome change, because despite the fact that we're told there's a huge number of unemployed GPs around, I know loads of practices who have been trying to recruit GPs for a year, 18 months, and they literally don't get any applications. So it's going to be a double-edged sword for those sorts of practices. You know, if they're not now allowed to use that for other health professionals, how do they balance?
Overall, I mean, just while we're on the topic of PCNs, it doesn't feel like it's a great contract for PCNs because they lose the 292 million to practices of the capacity and access funding. And then there's this phrase that's sort of tagged on at the end of the letter that there's a requirement for PCNs to, what it says is, achieve greater alignment with neighbourhoods. And it basically says there's going to be a primacy given to neighbourhoods. So if PCNs don't match neighbourhood configurations, then essentially they're going to have to. What's your take on what the contract overall means for PCNs and what you think about this alignment with neighbourhoods might mean in practice?
What is a neighbourhood, Ben?
Well, you know there was guidance coming out on that in October, then in November, then in February, and we've still not seen it.
Precisely. And that's the point, isn't it, really? And I really feel for our colleagues in the ICBs because they're trying to navigate this whole process and they're trying to follow the diktats that they've been given in terms of, furthering neighbourhood working and making sure that's up and running. And yet nobody's yet told them what a neighbourhood actually is. I think it's difficult for PCNs, but the one thing I would say is that the death knell for PCNs seems to have been sounded several times over the last few years. And yet they're still around. I know there have been some difficulties with them, and I know some PCNs probably haven't been that successful, but there are a large number of quite successful ones. So I think anything that undoes all the good work we've done so far would be very, very detrimental to general practice.
I think you're right, Pete, that we've heard of the coming of the end of PCNs over the last few years. And as we know, neighbourhoods now have been pushed back to next year, although there is ongoing work in some areas, including the area I work in. But I don't think we'll truly know what happens to what the plans are for PCNs until we've heard exactly what the plans are for neighbourhoods. There is too much invested in terms of time, staff, clinical capacity in PCNs to simply remove it. I guess undoubtedly, neighbourhoods will mean that it needs to be reshaped. The issue will be how it's reshaped in individual neighbourhood areas.
And again, I think one of the natural things that follows from that, Ceri, is that we're trying to get a standard system across the whole of England, but the ways already in which ICBs have decided to initially approach the neighbourhood question differs vastly. And I don't envy them, as I said earlier. I think they're really struggling to understand what's the best way forward when they've not been given any guidance. But I think you're going to get a lot of inconsistency, which inevitably then leads to further health inequalities, which is not something that any of us really want.
Now, the bit that stood out to me in the letter above everything else was this change whereby the advice and guidance DES is essentially being scrapped. Practices were previously paid £20 per advice and guidance referral. And instead, it says it's going to be like a requirement of practice. So the money's going to be transferred to core, but it's going to be like a part of core work. What's your take on that as a change? And what do you think the impact on practices of that change is likely to be?
I think advice and guidance prior to this year was used in a variety of different ways across the country, from what I can see. The area I work in tended to use advice and guidance pretty well alongside hospital colleagues in terms of agreeing pathways and so on. But I'm aware that there are other areas where advice and guidance was essentially a brand new service. So there was funding to accompany that in the last financial year. We've been told that the money for advice and guidance has been recycled into the GMS contract. But of course, as we said earlier in this podcast, that there is some opacity in terms of how the GMS funding stacks up and what part of the increase the advice and guidance money is. Ultimately, it's going to be mandated. There is concern, particularly from clinical colleagues, that will mean that they are restricted in doing referrals, which they know needs to happen. I tend to be a pragmatist, and I think this will probably work itself out. But there is a danger that individual areas will find that there is a different interpretation to that approach. I'm not saying it's a good thing that the funding has been removed, but we're practices. We tend to just get on and sort it out and deal with it and move on.
I think I'd agree with Ceri. It seems a bit odd to say to us, right, you definitely all need to use advice and guidance. You definitely need to do it. Here's some funding to support you to do it. Oh yeah, years gone, right, now it's core. I think that really does go back to this question of the smoke and mirrors about the funding increase we've got. But I think one of the other considerations is that quite obviously our colleagues in secondary care are really struggling too. We're not the only part of the NHS that's finding it difficult at the moment. And if you were to look at all the different regions and the way in which their referral processes work, and indeed in some regions, the way the advice and guidance processes work, they're not really fit for purpose. They don't do the things that it says on the tin. And again, I think all that does is perhaps increase the pressure on general practice, which is probably not what we all need at the moment.
Because it could get worse, Pete, couldn't it? Because, at least with the DES, you were getting paid per bit of work that you did. And, general practice has long had this argument that says, we just get one massive block. We're not paid for the actual work that we do. And it's really interesting to me that, Jim Mackey, so Chief Executive of NHS England, talks about evil block contract. This is when he's talking in the context of hospitals, and that they shouldn't be paid just block contracts, that it should be payment per item of service. And yet for general practice, we've got things moved away from an item of service into a block, just at a time when NHS England is trying to massively expand the use of advice and guidance. So it's going to grow. You can also guarantee that the funding isn't going to grow at the same rate. It seemed to me like it's a way of getting general practice to do more work for no more money, which is supposed to be the thing we're trying to reverse.
I think that's right, Ben. I agree with you entirely. And if you think back to the last lot of industrial action that general practice took, this was one of the key factors. We weren't just going to accept the transfer of work from other parts of the health service unless the funding followed. And you're right that this does seem to be exactly that. But I think, again, it's trying to look at it in the round. If in fact we had a secondary care service and all the hospitals were properly funded and everything was going great, we didn't have waiting lists, then it might be a little bit easier to absorb. I wouldn't support it, but it would be easier. But given the situation of the whole NHS, I think it's going to be much more difficult for everybody to manage. And again, morale, it's one of these nebulous things that it doesn't have a pound sign in front of it. We can't value it. But we all know that the whole question of morale and resilience is key to the way that anybody does their jobs in the NHS or otherwise. And this just chips away at that even further, I think.
I got the impression reading that letter that there's a kind of move from NHS England to try and set some almost like minimum GP standards, and that you would expect from that an expectation that be more sort of performance management of GP practice. So you've got to deal with clinically urgent patients on the same day. Then there's this clarification around non-urgent patients that an appropriate response is required by the end of the next working day. You've got to engage with the ICB if you've got unwarranted variation. And let's not get into an argument about what that might be. You've got to use advice and guidance. You're not allowed to cap online referrals, almost like the GPC's been saying, we need to be able to cap online referrals. It's like, we don't care what the GPC say. We're definitely not capping online referrals. And there's more in that letter. There's about 10 if you read through it. So do you think that's where we're headed, that we're going to see out of this a much sort of heavier performance management regime of practices?
I do. And there's a bit of me that is not worried, because I think for practices who are doing the job, that shouldn't worry them. The thing that worries me most about the performance management is what metrics are being used to manage. And we've long talked about GPAD being a blunt or not a very useful tool to actually compare practices in terms of the number of appointments they provide, because of the way that practices are set up and the way that some practices record their information. As an example, my practice is a total triage practice. We triage 100,000 appointments or 100,000 requests a year. None of that goes anywhere near our appointment book. And yet that's all activity that our GPs are doing. And so how are we going to be measured? And are we actually comparing apples with apples when we're doing that? It's not the fact that we will be performance managed. I don't have an issue as a manager of a practice who's got a contract in that happening. But what I do have is when I have concerns about the data that's being used. And there's still, again, some questions about how that's going to happen.
I think there's another provision, if I've read it right, Ben, in the contract where it talks about some data gathering and submission, and practices are going to have to submit data in 5 different metrics. Now, just to pick one of those, we're supposedly going to have to submit data about call waiting times between 8 a.m. and 10 a.m. The vast majority of practices that I know have systems that basically answer the phone automatically and place you in a queue. So the call waiting times are about 2 seconds. If that's what they're measuring, how is that going to actually materially improve patient care or the service to patients? I think the devil as ever is in the detail. And if we can sit down with the Department of Health and NHS England for as long as it lasts, and actually talk to them about this and agree some sensible metrics. And like Ceri says, I think the vast majority of practices will say, okay, we think it's fair. We think you're looking at reasonable things. But if we get silly ideas imposed on us, people are just going to work out ways to get around that. And I don't see who that helps.
No. And we haven't really seen over recent months or even years this sort of willingness of NHS England to sit down and talk to practices and work out sensible things. It seems to be rather we want to just tell people what they need to be doing. But we'll come back to response. I just want to touch on the QOF and changes there and get your take on that. So there's 2 new indicators primarily around obesity, so referral to weight loss programs, and then the prescribing of the weight loss drugs, and then obviously the changes to the child vaccination targets. What's your take on those changes?
If I just comment on the weight loss services, in my region, we actually had an email this morning because the weight loss services that have been contracted have basically run up waiting lists. Again, not blaming them at all, because I'm sure they get vast numbers of referrals, but they've run up waiting times of sort of 6 to 8 months. If that's a service we're going to have to refer into, how's that going to help? If that's what we're measured on, how's that going to help?
I guess just to add to the bit about weight loss, though, is failing must sound like a bit like a stuck record, is we don't know what the detail of that is yet, really. My biggest concern, whilst I think the additional focus and the income that we will get potentially from that is positive, is the message that is going out to patients, and lots of people will want to access this but may not be eligible. I'm not sure that message has been made very well.
It's almost deliberately not been made, hasn't it? If you look at the publicity that went around the letter of the new GP contract, it was saying, it'd be much easier for you to access these drugs through your GP, and no mention of the criteria that have gone up. And the stories even today about then individual ICPs putting even more criteria on access to these drugs. So what potentially could happen is you're going to have a stream of patients turning up wanting access to the drugs just to be told that, no, you can't have it.
Exactly that. And that means the practices have to say no, and we get the understandable flack from the patients who haven't been given the whole story. Thinking about childhood IMS, the perennial thorn, really, we were asked to comment as a second round, really, of consultation in relation to the proposal for an additional way that practices who struggle with childhood IMS targets could achieve and be incentivized to increase the number of patients who have the immunizations. I think in principle, I don't disagree with the offer, because at the very least, it's not going to incentivize, but it may well mean that some practices feel able that it's worthwhile making an additional effort over the next year. I think in some ways that's a bit disingenuous to think that some practices weren't making an effort, but undoubtedly there are practices where they're in areas of vaccine hesitancy for whatever reason, whether that's social or cultural. Even asking them to increase by 5% is a big ask. But it's there as an offer this year. It'll be interesting to see whether it does make a difference in those areas. Lots of practice managers I talk to say the thing that would make the biggest difference, and we fed this back, is an ability to accept patients where you've made an absolute clear effort and had a discussion with the patient or with a parent about the reason for not wanting the vaccine. An example would be that after you've done the various invites, that a GP has to have that conversation and to document their discussion with the parent about the importance of vaccines. Now, that doesn't appear as part of the contract this year, and whether it will in the future, who knows? But I think there are, even in high-performing areas, the 96% target is a significant ask.
Okay, so the contract is what it is for now. It's the GPC met last week and they rejected the contract, and I understand there's now going to be a referendum of the profession. The contract does strike me as one where it has the feel of one that's being imposed rather than negotiated, because there are things in there that if they were trying to negotiate, they wouldn't have come out, like advice and guidance going into the core contract. So what's your overall take? I'm interested, particularly from an IGPM perspective, what you think in terms of what should happen now, and what do you think will happen for the profession as a whole?
I guess from an IGPM perspective, practice managers deliver. Day in, day out, we get things done, we look at the contract, we look at the detail and work out ways of delivering it. But ultimately, we are part of a bigger system. Pete and I are both partners in our own practices, but partners and partnerships will need to decide what they do in relation to the ballot that is ongoing now with the BMA. And then ultimately, whatever the outcome of that and the next steps, will need to decide whether they participate or not. But from a purely practical perspective, practice managers will pick this up and will make it happen. However frustrated we might be with the detail of the contract, I certainly wouldn't want to give the impression that, as an organisation that was consulted as part of the contract this year, that we are happy with the contract. That would be a stretch. We are happy that we were at the table and having those discussions, and we can see bits of the contract where we gave feedback and it's been amended as a result. So any championing or us saying, well, we were successful in helping shape the contract this year, it has to be tempered by the fact that overall the contract still has some areas of concern for practices.
I think I'd probably echo most of what Ceri has said. Our practice and PCN management colleagues do just deliver and buckle down. What worries me is the slow drip effect of contracts where we're not properly funded, where additional work gets foisted upon us. And we've known for many years that there are practices who are literally clinging on by their fingernails. And a few more this year will fall off the ledge and they won't be able to continue. And all that does is heaps further pressure on all the surrounding practices, and you get a potential domino effect. The bit I still can't understand is why this government decides that the way to progress, the way to move forward, is to just impose and just do to people. Because if they genuinely wanted to improve patient care, if that's the driving force behind what they want to do, then we all know that working collaboratively is the best way to achieve that. If you just dictate and use a big stick on people, you don't get the response. You don't get the way forward that you could get by working collectively. And I think, again, any industrial action, whatever format it takes, is still going to harm patient care. And that isn't a good thing for anybody. We're all patients, as well as being practice managers, we're all patients. And we want to be able to see our GPs and get a good service from them whenever we need it. I don't think this contract moves us in that direction at all.
Well, thanks both. There's a lot to get through. My own personal opinion is that the contract is disappointing, and that there is a real concern about a precedent being set that the NHS and the government can just decide what's going to happen to general practice. Because whilst it could have been worse, it potentially will be worse if this system is allowed to continue into the future. But let's see how the next few weeks play out. Like you said, Pete, we do need to see the detail of the actual contract, which we probably won't see right until the end of March. Thanks both.
Thanks, Ben.
So in the podcast today, we talked about the GP contract and the ever-changing primary care landscape. Practice Index is here to help support practices with policies, compliance, finance and more. The Practice Index Hub brings everything together in one place, from HR and learning to compliance and rotas, making it easier to manage the day-to-day running of your practice. Find out more and book a demo by heading to practiceindex.co.uk.
The General Practice Podcast from Ockham Healthcare, supporting innovation in general practice.